we're going to go ahead and get started. So we are going to talk about withdrawals today. I know that we talk about it often, but it's important that everybody's on the same page about this. I'm going to share this screen with you. Can everybody see that? If somebody could say yes, because I can't see you when this is up. Can everybody see that when I had that up?
I
No?
don't see anything.
Okay, let me try it again. Well, oh, I did the wrong thing. Here we go. All right. How about now? No. Oh, goodness. Okay, give me just a second. It worked a minute ago. If I can't get it this time, we'll just move on. Okay, so I can't get it to work this time for some reason. Sorry about that. But we'll start with opiate withdrawal. Some of the signs and symptoms of that are nausea, vomiting, stomach cramps, diarrhea, goosebumps, depression, and cravings. They can also be sweating, have runny noses, teary eyes. It can start anywhere from 6 to 12 hours after their last use, maybe a little longer for long-acting opioids. But make sure that we're monitoring. I know some jails have, when they ask initial questions, they ask if there's a chance for withdrawal. My facility doesn't have that on theirs, but so if somebody's going to withdraw, it is very important that your officers know that they should be contacting you if you're in the building right away, or the provider if you're not. Same with MTPs, they need to be notifying the provider right away. Hydration in any withdrawal is absolutely the most important thing that we could do. They should be drinking at least every hour. So, alcohol withdrawal and benzo withdrawal. Benzos starts anywhere from 6 to 12 hours after last use and generally peaks at 2 weeks. They can have seizures, sweat, slurred speech, shaking, depression, difficulty sleeping. And then if you Xanax, Ativan, Klonopin, Restoril, these are some of the most common benzos that we see in our setting. And it is also considered a medical emergency. Again, make sure that we are notifying our providers right away. And your staff should know that if you're not in the building, they need to be doing that, or they need to notify you right away. Alcohol withdrawal, the symptoms are similar to benzos. They can have anxiety, sweating, increased heart rate and blood pressure, tremors, hallucinations, seizures. So if any of those things are occurring, make sure that you're monitoring those. If they're having hallucinations or seizures, that definitely is a call to your provider. And if it's that bad, you use your clinical judgment. I would send them out and then notify your provider. But if any of those things we're monitoring are outside of our normal parameters, you should be notifying your provider of those anyway, in case they want to give different orders. Our process for any withdrawal is the same. You get a urine drug screen. And then you're going to verify if you have an MAT program, you're going to notify, or you're going to verify a current prescription for that stuff. Then you're going to contact your provider and get orders for any supportive meds that might be needed, what kind of monitoring they want, how often they want it, and just make sure you're staying in contact with your provider about those things. If anybody can start a withdrawal protocol, okay, but what do we have to do before we stop monitoring? What do we have to do? Nobody?
Get the order from the provider.
Yeah, thank you, Lisa. Always make sure that you're getting an order from your provider to stop any kind of monitoring. Make sure that we are documenting how we contacted the provider, what provider we contacted, and any orders they might give, and make sure that we are documenting that. Because if they're doing your audit and they don't see an order to DC the monitoring, they're gonna ding you on that. What else? Make sure that your MTPs and officers know that they should be using the withdrawal flow sheets, and nurses need to be using the COWS and CWA. What else am I missing, Jolene? Or can anybody think of anything else that I'm missing?
Can you hear me? Hello?
Can't hear nobody. Jolene's frozen. Corey's in a bad area. Stan's on the phone.
Sandy, sorry. Rosie, I can't think of anything else. I think you've hit on a lot of this stuff.
Okay. I just don't want to miss something that I should be saying.
Yeah. I think.
Can you hear me?
Yes.
You can hear me?
Yes.
Sporadically.
Very good. Okay, sorry, I know. I'll just skip it. Just make sure when you're checking your people's charts that you see this reflected in there, that they're getting the order to discharge and putting it in. It's definitely something we see when we audit sites quite a bit, like about this a whole lot, like we do too. We're trying to stop talking about this over and over again also. And so just when you're in their charts, make sure this stuff is in there, please.
Something else too, if somebody comes in and they blow, like I had somebody come in here and they blew a 0.267 and they were walking perfectly normally. This person denied that he had an alcohol problem. But you should probably put those people on your radar until they're not on your radar. Despite what they say, we should probably be checking in on them, making sure that they're doing okay. Because sometimes people don't admit it right away, but then they start having symptoms and then they'll say, yeah, I need something. Or even if you notice it, notify your provider. We can get the order and offer them. And if they refuse, that's on them, but we've done our due diligence. Anybody think of anything else that we might need to do? Also, one more thing too is mental health symptoms from withdrawal can last for a very long time. So just make sure that we're also paying attention to these people's mental health. If we need to get them to see mental health, you know, something like that, we need to make sure we're taking care of them. Suicidal thoughts increase with withdrawal, so it's important to monitor that as well.
I'm guessing about everybody on here is a 24-hour facility, so the nurses and then sometimes you get an order from the provider and it says COWS or CWAS twice daily, but that's not really reflecting what's going on, because you may have MPs over the night shift, and of course they have to do the withdrawal protocol. You can't do the COWS or CWAS, so I try and talk to my provider, and because I'm on a little facility, and I'm like, you know, COWS or CWAS daily, but when nurse is not in building, officers are to do the protocol every 4 hours. So we're kind of doing both at the same time. And I'll help the officers when I'm here fill out that protocol so that so when I do a cows or a CWAS, I said, bring that piece of paper with them, fill it out for them so that it looks like they're doing their job and I'm doing my job at the same time and I'm helping them out and they like that. But again, we're here to lower liability. So we want to make sure that if withdrawal monitoring isn't being done at the appropriate times, and sometimes if you're monitoring your own facility, go through and if there's paper come along, take a look at it. Let's make sure that things are being done.
And, you know, it's another one of those things where they can refuse to get up and let you take their vitals, and they can refuse to answer your questions, but you can still document on them. So you can document what you're seeing.
Yeah, don't just put refused and no documentation.
Anybody have anything else or any stories they'd like to share? Or
Yeah, actually, I had a question maybe for the group help. Something that came up in that first training was if officers aren't doing it or not doing it consistently, like going to talk to the jail commander. And it almost seems like maybe, and this is for those of you that don't know me yet, I do the officer training now, and we talk about that. We show those slides that you showed, talk about the importance of it. But when we find out, okay, there's someone that needs that monitoring, is that being told to the shift supervisor so that they can make sure the officers are tracking it, or is it just told to one of the booking officers kind of offhand? So that part, and then if they're not doing it, going straight to the jail commander. That is a complaint that I hear sometimes from some of the jails is we're skipping big chunks of people that could help solve that problem and going to the jail commander first. I don't know if that's an issue, if that's just stuff I'm hearing from officers because they do complain a lot too. But just the process for, okay, we have this monitoring, who's the ultimate person on that shift checking to make sure that that's getting done on the officer side. I don't know if that's an issue anywhere or if that's just.
That's a tough one because I would take it to the sergeant or shift supervisor, and then if it continues, I'd take it to the jail commander, and I'd get your pedal involved too at that point.
I think.
yeah, and I also like our process for letting them know somebody is on withdrawal. Here in my facility, we have an electronic board with all of our patients on there. And if somebody's on withdrawal, they get a WD in red beside their name. So that officers have no excuse. They can look up there and see that person's on withdrawal. Plus we have a physical handwritten shift to shift report sheet, letting them know this is going on. So this is what you need to be looking for. Plus shift, verbal shift to shift communication. I know in my jail, honestly, it is terrible. And that's why we instituted the handwritten shift to shift. And even then still so I always try to make sure that the oncoming shift knows. But yeah, again, you can talk to the shift supervisor, the sergeant, whoever's the lead officer. And then if you don't get satisfaction that way, then you should go to your jail commander.
Coming from the Challenge Academy where I was at, we had that issue where we called them cadre, but think of them as officers. You tell an officer that something needed done, they'd forget, they wouldn't do it, they didn't know how, whatever the issue was. A lot of times if we went to that shift supervisor and said, hey, these two people, for example, need this withdrawal protocol, can you make sure it gets done? Then they were on the officers to make sure it got done, and that went to them. It just seemed like it was, for us, it helped a lot to go to that shift supervisor, but every jail's different and relationships are different. So I just wondered before it went straight to the jail commander of, hey, your officers aren't doing this, is there a step in between to make sure that they even knew? They should know, obviously, whatever the process is in the jail, but that shift supervisor, that sergeant should probably be a point of contact, I would think, each time.
Yeah, and every facility is different. So I guess it's kind of up to medical to figure out what works for your facility.
Yeah.
You know, do I need to tell this sergeant? Do I need to write it on a board somewhere? Do I need to talk to the jail commander right away? So every facility is different. So you're just gonna have to figure out what works for your facility. And if you need help if anybody needs help trying to figure that out, you know, call your pet or call your CSP and ask them, or call a pedal.
Yeah, now you think about maybe following it up with an email and including your pedal and maybe the jail commander in the email. Hey, I had this chat with so-and-so. That way it's documented because they could always come back and say, they never talked to me about it.
I know, and I think probably most of the facilities on here have a pass down channel, or all of us have pass down channels. I'm the only nurse here, so I don't use mine, but make sure you put it in your pass down channel. I know not all the officers have access to that in every facility, but if they do, that's an excellent way to communicate it as well. So it's documented that that was communicated.
Yeah, Rosie, I have a shift report that I send. I don't use it in ZenZap because the officers don't get ZenZap. I have a pass down channel that I send to the officers. And of course, sometimes they read it, sometimes they don't. And I have one guy's like, oh no, we're only doing blood sugars on him once a month, and they're getting a refusal on him every day. Okay. We need it once a
Yeah,
month.
I write on their shift to shift report. I just go up there and write on every shift if I need to.
So remember that the suicide watches and the withdrawals are where lives are at risk. And sometimes I have to remind our staff members that, hey, we're there to lower your liability. This is why we do this, so that we all don't get sued and nobody dies, because I don't want anybody dying in my facility.
Yeah, and sometimes, unfortunately, it takes something excessive to happen before they understand the importance of it. And that's unfortunate, but just always stress how important it is for them to make sure they're staying up on that.
Yeah, they probably don't know that somebody tried to choke themselves with a hot dog at another facility. So they you know, it's like, and the importance of cutting that up into bite-sized portions. Well, you can still shove all those portions down here. So we heard a story on the last call that somebody was tearing up the foam on the floor of the padded cell and was trying to choke themselves with the foam on the padded floor.
All right. Anybody have any more questions or any more thoughts on that? All right. Well, if you guys need help or have any questions, reach out to your CSP or reach out to a pedal. And if we don't know the answer, we'll direct you to somebody who does. You guys have a great rest of your week.